I am really pleased to introduce Dr. Kelly Moore. Dr. Moore is a licensed clinical psychologist and assistant professor in the psychology department at East Tennessee State University. After earning her doctorate, Dr. Moore completed a postdoctoral fellowship in substance use prevention research at Yale School of Medicine. Dr. Moore's research aims to improve behavioral health among people involved in the criminal justice system. Much of her work has centered around reducing stigma-related barriers that impede engagement in evidence-based care for addiction and other mental health problems. Today, Dr. Moore will share how stigma influences behavior and treatment seeking, plus how you can help reduce stigma. This series is brought to you through a partnership between University of Tennessee Extension and East Tennessee State University's Addiction Science Center, and it's part of an effort funded by USDA to address opioid misuse and abuse in Tennessee. And I'm Lisa Washburn. I'm a community health specialist and associate professor with University of Tennessee Extension. Welcome everyone, and Dr. Moore, I will turn it over to you.
All right, thank you so much. I'm really excited to be here and to talk about stigma. It's something that I am really passionate about, and it's been a research focus of mine for a while. So I'll go ahead and get started. So today I'm going to be talking about how we treat opioid use disorder, and then also talk a lot about the stigma around opioid use and how to recognize that and some of the consequences of stigma for treatment. And then I'll end with a few ways that we can all reduce stigma associated with opioid use. So first, it's important to just get on the same page about what opioid use disorder actually is and how it's treated. So opioid use disorder, which I'll call OUD, is a severe illness that is characterized by a recurrent use of opioids, including prescription pain-relieving medications or heroin, despite negative impacts that it has on health, family relationships, work functioning, school functioning, and other areas. And people with OUD have really intense and strong cravings and urges to use opioids when they don't have them. And they can also have what's called tolerance, where they need to use more over time in order to get the same sort of euphoric or pain relieving effects. And then they could also have withdrawal symptoms, which are a wide range of physical symptoms when you don't have the substance. And people with OUD also have a kind of a persistent desire to quit or unsuccessful efforts to quit, like they've tried and they haven't been able to. So that's a little bit about what opioid use disorder looks like. And just in terms of how common this is, over 2 million people in the US have been diagnosed with opioid use disorder in 2018. And it's a very severe illness. There's a high rate of both non-fatal and fatal overdose, risk of hospitalization, risk of involvement in the justice system, and lots of other negative consequences that people experience when they have this disorder. So specialty treatment is recommended to help people stop using opioids and recover from this addiction. So what does treatment for opioid use disorder look like? Well, let's start by just talking about what treatment shouldn't really look like for opioid use disorder. And these are some of the more common treatments that you would think of when someone has an addiction that are not actually recommended for OUD. So inpatient detox, where people go into a facility and just sort of, get clean and from the substance, that's not really recommended because decreasing someone's tolerance to opioids like that actually increases their risk for overdose if they do have a relapse. So that's not generally recommended. And then just in general, substance use programs that don't offer medications, which I'll talk about in just a moment, are also not recommended just because of the intense physical symptoms and cravings and withdrawal symptoms that people experience when they have OUD. So effective treatment, what that looks like is a combination of three things. One of them is medications. That's the most important thing that I'll talk about next. And the other two aspects of treatment that are necessary are counseling, which could be group or individual counseling to address things like trauma and emotion problems and lack of coping skills that we know tend to make addiction harder and can affect people with addiction. And then also recovery support. So when people are able to stop using opioids, building in a support system so that they can have social support and access to services they need, such as through groups or peer specialists who have experience with opioid use who can then connect people with services. So those are the 3 types of treatment that are recommended, a combination of those for treating OUD. And I wanted to talk a little bit about what medications look like and how they're effective, because that's not always something that we know about. So there are 3 FDA-approved medications for OUD. The first 2, the most common, are the opioid agonists, which means they actually bind to the opioid receptors in your brain, and they activate them. So through doing this, they reduce a lot of the negative symptoms people have when they stop using opioids, such as cravings, withdrawal symptoms. And then through that, they can also increase people's engagement in substance use treatment, and reduce the likelihood that they'll relapse and use illicit opioids. Through the reduced opioid use, they also reduce things like overdose risk and contracting infectious diseases and engaging in criminal behavior. And they also improve birth outcomes for women who are pregnant who are struggling with opioid use. So in general, opioid agonists are definitely the gold standard treatment for opioid use disorder, highly effective, very, very effective when people take these and are maintained on them. The other medication is an opioid antagonist, which means it doesn't activate the opioid receptors in the brain, but it still goes in there and it blocks opioids from having any sort of euphoric effect. So people don't want to take them because they're not experiencing the same effect. And it has similar effectiveness to the opioid agonist. It's not used as common yet, but it's kind of gaining more popularity. And just in terms of how these medications are taken, there's a lot of different ways people can take the opioid agonists, which are methadone and buprenorphine. Methadone is usually taken orally once a day. Buprenorphine can be taken orally. It can also be taken by implant or by injection. And then naltrexone is generally taken by injection once a month. So we have these really effective treatments for opioid use disorder, and we also have things like counseling and recovery supports that we know are really critical and helpful for people who are struggling with this illness. So what is actually the issue? Well, some data has come out from the Substance Abuse and Mental Health Services Administration showing that only 20% of people who really need treatment for opioid use disorder actually receive it. And then among people who are in treatment for OUD, only 40% of those are actually getting those critical medications that really are what really helps people recover. And it's even less if people are actually getting their treatment in the justice system, because there's lots of other issues related to having the medications in that system. So one of the articles that I read recently, one of the studies I read was talking about just the barriers to providing treatment for OUD. And I found this quote that I really like, and it says, "For no other condition for which an effective treatment exists does the healthcare system fail to give that treatment so frequently." And if we think about this, we have these really effective medications for treating opioid use, but they're not really being given, or they're not reaching people who actually need them. So what's going on? So that is where stigma comes into play. There's been a lot of talk about how stigma is one of the major reasons people with opioid use are not actually getting the treatment that they need to recover from this illness. So I'm going to talk about what that is. So stigma in general is just any sort of attribute or part of your history or a condition that you have that's generally devalued in our society. So some examples of this are having a criminal record, having a mental illness, being in poverty, having a substance use problem, being homeless, or having chronic illnesses like HIV/AIDS. And these sort of conditions or attributes or parts of people's history is generally just in society not viewed very highly. And we know from decades and decades of research studies that people with these sort of stigmatized attributes actually have very different health outcomes, both in terms of their mental health and their physical health. So we know they struggle with more anxiety and depression, stress, low self-esteem and self-efficacy, and they engage in things like avoidance, isolation, withdrawal, and also have trouble engaging in treatment for some of the conditions that they really need treatment for. So we know that people in stigmatized groups have all sorts of struggles. And the way that stigma actually impacts behavior is, so there's three main ways. The first is through structural issues like policies or regulations that somehow prevent the stigmatized people from getting access to services that they might need. The social aspect of stigma is just the stereotypes or the attitudes that people in the general public have about the stigmatized group and how they treat those individuals. And then the self aspect of stigma is how stigmatized people respond to these sort of stigma stressors that they encounter and how they feel about themselves as a result of having this kind of stigmatized identity. So these are the three main ways that stigma impacts behavior and impacts stigmatized people. And I'll talk about what this actually looks like for substance use and opioid use specifically. So structural stigma, again, these are those policies or regulations that impact people with the stigmatized condition. So with regard to substance use and opioid use specifically, certain medications for opioid use, methadone being the major one, are often not able to be accessed by many people. So they can only be administered in licensed opioid treatment programs rather than regular medical facilities. And so this really limits access and makes is stigmatizing in the sense that it kind of separates out people with opioid use from just having an illness that needs to be treated. It says that there's something else, they need to go to this other place to get their treatment. And methadone in particular, methadone clinics and going to get daily doses of methadone has been referred to as liquid handcuffs because people who go to receive methadone to get a daily dose of methadone, usually they have to go to a clinic every single day to get a dose, and they're drug tested regularly. There's such intense surveillance on their treatment. People often look at it more like probation than treatment. So that can be very stigmatizing. With regard to buprenorphine, which is the other major medication that we use for opioid use, there are also restrictions on how people can access that. So only people, physicians who have a certain training can provide buprenorphine. And those sorts of trainings they're called waivers, are not very common. That's actually changing right now as we speak with some legislation that's making it easier for physicians to give buprenorphine to people who have opioid use problems. But up to this point, that's also been one of the ways in which there's some policy and regulations that prevent people with OUD from actually getting access to care. And then other policies and regulations just have to do with the criminal justice system, and medications for opioid use are not even available in that system. So when people with opioid use get incarcerated, get arrested, oftentimes there's no treatment available to them with regard to medications. And that's a really, really big problem. So thinking more about the social aspects of stigma, there's a lot of negative stereotypes about people with substance use disorders in general. And oftentimes, if we think about just the language that's used, addicts, referring to these people as addicts or junkies, is common. And some of the most common negative stereotypes have to do with addiction being a moral failing rather than an illness. So that it's something that people are choosing to do and it's their own fault, and therefore they kind of deserve to be punished, deserve to be blamed for any sort of negative thing they experience. That's a really common one that a lot of people have. Also, there's attitudes about substance use problems that people are just being lazy, that they're not trying hard enough to stop using drugs, or that they're untrustworthy, that they're always trying to manipulate or be secretive or take advantage of people. There's also attitudes about people with substance use disorders just being different from me or different from you, that there's something wrong with them, when in reality we know that addiction can really happen to anyone. But these are some of the common attitudes that people have that are prevalent in our society. And these sort of attitudes are even more severe if people are pregnant or parents and they have substance use problems, or if they inject drugs, or if they're involved in the justice system. So when thinking about attitudes specifically about opioid use disorder and medications for opioid use disorder, which is that acronym there, MOUD, there was a survey that was conducted recently with people who were just living in rural areas of the US, and it found that 68% believed that OUD was a real illness, which means that a good chunk of people didn't even think it was a real illness. Only about half said that they would even live in the same area as somebody who had opioid use disorder. Almost half thought that people with OUD were dangerous and thought that they shouldn't have the same rights to employment as people without OUD. So that's really kind of letting that sink in a little bit. Some of these attitudes about people with opioid use that are very common in rural areas and other areas. The one good thing that the study showed was that 70% of people really did recognize that medications were an effective treatment for OUD, which is a good thing. And that's a good thing because stigma is actually particularly severe about medications for opioid use. So there's stigma about people with opioid use just in general, and then there's stigma about the medications for opioid use. And it's particularly prevalent in the healthcare system and the criminal justice system, surprisingly. And those are the two major systems where people are actually getting treatment for the most part when they have opioid use disorder. So we see a lot of beliefs about medications not actually being a real treatment, that medications are just another drug people are getting high off of, and thinking that people aren't actually abstinent if they're taking medications for opioid use, which, this is just, when we think about this, we have an effective medication, a treatment for this illness, but there's all these negative attitudes about what taking the medication actually means, and attitudes that it's not good enough, it's not an effective treatment, and people just need to be totally clear of any sort of substance. And so that third aspect of stigma is how the stigmatized people actually feel and how they experience these other types of stigma they encounter, the structural and the social aspects of stigma. So studies looking at people who have substance use problems in general have found that they actually perceive quite a bit of stigma. And they expect to be treated unfairly from a lot of different people. So we can see here 44% of people with substance use disorders think that other people devalue them. Almost 60% think that most people wouldn't trust someone who's been treated for substance use. 75% think their family holds negative stereotypes about substance use. And then there's been studies looking at, after people found out about your substance use, what did they think about you? And people with substance use problems, 60% of them thought that they were treated unfairly, that others were afraid of them, that their family just gave up on them, or they were rejected by friends. So these are some of their own experiences and what people with substance use problems are having to think about and struggle with on a daily basis. Specific to opioid use, there's been some really interesting research studies looking at what these people experience, and people who have opioid use disorder think that most people believe a person who has an opioid use disorder can't be trusted and is dangerous and is to blame. And this can actually trickle down to something that's called internalized stigma, and people can come to start believing these things about themselves. They can think like they are to blame for their addiction and that they aren't trustworthy and they aren't going to be reliable and they can never succeed with anything. And that's actually a very big problem, because it can make people not want to keep trying to actually recover from their addiction. It can be very disheartening for them. I pulled a couple of quotes from a study that looked at people with OUD who were receiving methadone treatment and just what their experience is like. So the first one says, "Now it's like anytime I ever need any pain for my muscles or for anxiety, it's like I can just tell that they either don't want to give it to me or think I'm lying because I'm not in pain. Speaking to just that, how healthcare providers might have some of that stigma about people who are seeking care. And then the second quote says, they look at you like you're a drug addict, and then they look at you like they can treat you any way they want. So just getting at that perception of stigma and really feeling judged by other people. Okay, so let's talk briefly about the consequences of stigma for treatment specifically. So most pertinent to substance use stigma, I think, is thinking about the consequences that we see in the healthcare system. So we know that healthcare professionals, specific to thinking about medications for opioid use, often don't really want to prescribe medications for opioid use, and they don't really think of this as being an effective treatment or a long-term treatment that people should be using to treat their addiction. And so in general, when healthcare professionals do have stigmatizing attitudes about substance use in general, we know from lots of different research that these people actually have poorer communication and alliance with their patients, and they misattribute, people that are coming in for physical problems and just kind of assume that they're drug seeking. These sort of providers who have these stigmatizing attitudes also have shorter visits with clients and less engagement with them. And we know that they're less likely to refer people to receive medications for opioid use, and they just are generally less supportive of policies that could increase access to this medication. So stigma that exists at the level of healthcare providers and other people in the community is really, really problematic for treatment, and has very, very big implications for people receiving treatment for opioid use. I pulled another quote from a study that was looking at, it was talking to addiction treatment professionals about their experience, and this quote speaks to some of the stigma that they witnessed in other healthcare professionals, EMTs in particular. So it says, we see EMTs here, there's a lack of training. Oh my God, I got to deal with one or more of these people. It's just the stigma towards the patients of, oh man, you people need to just stop using, and sort of getting at some of these ideas and beliefs that EMTs have about the people that they're treating, the people they're coming to help, just kind of writing them off if they think they have a substance use problem. And then self-stigma is actually also very problematic for treatment, because if you think about it, people with substance use problems or opioid use problems in particular, if they perceive a lot of negative judgments, and if they expect to be judged and looked down upon and treated negatively and rejected, especially from healthcare providers, that really impacts their desire to seek treatment and to remain engaged in treatment, especially if they perceive these sort of negative judgments or attitudes from the people that they're receiving care from. So we know from some research studies that people with OUD report thinking that medications are viewed as just the same as using illicit opioids. And we know that perception is accurate, because a lot of healthcare professionals do, endorse having these attitudes that medications are just another drug. And people with OUD don't want to feel judged. They don't want to feel that way when they're trying to get treatment. People with OUD also experience a lot of pressure from family and sometimes healthcare providers to stop using medications for opioid use. So that's a big direct impact on treatment there, if they're actually experiencing pressure to stop using the one type of treatment that's actually going to be effective. And then we see that this kind of influences how people with OUD actually think about the medications themselves. So because methadone in particular and other medications for opioid use are so highly stigmatized, people with opioid use problems don't want to be on methadone. They start to feel worried about that, and they don't want to be on this drug that they think is a drug. They think it's just another drug, so they don't want to take this medication. So in terms of what you can do and what anybody can do to start reducing some of the stigma around substance use problems and opioid use problems, the first one I think is trying to challenge how you think about addiction, and whether you think about it as being something that's totally controllable and under people's control. It's their own responsibility, it's their choice, versus an illness. And there's a lot of reason to think of addiction as an illness. I won't get into that. I think that's been covered in some of the other talks, but trying to shift our thinking about addiction as an illness that requires both medical and mental health treatment, rather than just some sort of choice somebody is making. The second thing I think would be to challenge and first become aware of stereotypes you might have about people with addiction, and then start to challenge some of those. And one of the ways I think is helpful to do this is to remember that addiction can actually impact anybody. It's not just one type of person that becomes addicted to drugs. It can really affect anybody who's using prescription pain relievers, in particular when we're thinking about opioid use. And then the third is remembering that people do actually recover from substance use, they recover from opioid use, and thinking about those sort of success stories. And if you've not been exposed to any success stories, I would recommend kind of seeking those out and thinking about those, as well as some of we're kind of inundated with these negative stories about relapse, but trying to balance that with some of the success stories. And I just wanted to end by saying in Tennessee, there is the red line, which the number is on the slide. You can call this number if you need to find information about substance use, referrals for treatment, and anything like that. So it's a really good resource to have for getting people connected to care. And that's all I have.
Thank you so much, Dr. Moore. If you guys have questions, you are welcome to put them into the Q&A. We still have a few minutes left, or you can put them into the chat. And while people are thinking, Dr. Moore, we spoke yesterday and you shared an analogy between chronic disease treatment and substance use treatment. And I wondered if you would be willing to share that again.
Yeah, and I think I put it on the slide, but I didn't actually say it. If you think about some of the chronic illnesses we have that are partly driven by behavior, right? Like if you think about high blood pressure or diabetes, which we know are impacted by things like diet and exercise, as well as other sort of biological factors. Denying someone with those conditions, denying them access to medication, or not telling them about medication or providing that. That's what we think about when we don't provide people with OUD access to medication. It's a very similar kind of thing there, and it would just be unheard of to do that for someone with high blood pressure or diabetes, but it's very common among people with OUD to not have that access to medication.
Thank you for that. We don't have any questions entered yet. Can you talk to us about how a community member could address stigma? Like, let's say that they're in a situation and maybe they're even recognizing stigmatizing attitudes within themselves. What would be a way that they could ease maybe some of the discomfort that they have?
Yeah, I think the biggest thing when I work with people to reduce stigma is just recognizing that, it's normal to have these sort of stigmatizing attitudes. They're just prevalent in our society. Drugs are bad, people who use drugs are bad. That's sort of a message that we all get. And so recognizing that you're not a bad person for having these sort of attitudes, it's just something we've all, kind of been exposed to. And then I think once you kind of normalize that for yourself and recognize that it's not, it's okay that you have these sort of attitudes and judgments, is then just starting to be aware of which ones you have, and then how they kind of, come out. So whether you're using certain language to describe people who have substance use disorders, or whether you kind of treat them differently. So starting to recognize those behaviors, I think, is the biggest thing people can do. And then just, as you become aware, just gently challenging yourself to not engage in those things, like not use terms like addicts or junkies, or think about how you could be more inclusive and accepting of somebody with a substance use problem.
Well, that is a good lead in to some information about our next session in June. So we'll be discussing how we talk about substance use and addiction, and that session is on June the 23rd. Thank you so much, Dr. Moore, for being here today, and thanks to the team from ETSU and UT Extension who helped to produce all of this. You can sign up for future webinars at prompt.tennessee.edu, and that is also where you will find recordings of previous sessions. Thanks to everyone. Have a great day.